I want to welcome everybody to the session, and I want to say the LSUH Center is proud of Louisiana's scientific response to the COVID pandemic. Researchers from around the state are working on the front lines, conducting research to improve testing, surveillance, health impacts, and treatment. And as a resource to all scientists, clinicians, and citizens, we've launched the Louisiana COVID-19 Chronicle Seminar Series. It started in October of 2020, and the LSUH Center is hosting a virtual reoccurring COVID-19 seminar series featuring scientists and clinicians showcasing the work that's being done right here in Louisiana against the battle against COVID-19. Topics and speakers for each seminar are announced to the LSUH's email list, the calendar of events page, and Twitter as they are finalized. We want to congratulate the researchers who have been successful in contributing to our knowledge on COVID-19, and we hope that you'll join us for future episodes on the LSUH Center's Louisiana COVID-19 Chronicle Seminar Series. So just a couple of housekeeping announcements. During the talks, please type your questions in the chat window, and we'll save time at the end to share your questions well, we have one speaker today. And it gives me great pride to introduce my colleague and friend, Dr. Suzanne Tinsley. Dr. Tinsley received her master's in physical therapy from Texas Women's University in 1986 and her PhD in neuropharmacology from LSUH-Shreveport in 1999. She's been on the faculty here at LSU for 31 years, 2 years longer than me. She is the Assistant Vice Chancellor of Institutional Advancement at LSU Health Shreveport, as well as the Assistant Dean. And she holds joint appointments of Associate Professor in the Department of Rehabilitation Science, the Department of Pharmacology, Toxicology, and Neuroscience, and the Department of Neurology here in Shreveport. In February 2017, she was named the first Richard C. Parks Endowed Chair in Neurological Rehabilitation by LSU Health Shreveport. She is a board certified neurologic physical therapist and is part of the clinical faculty for the Neurologic Physical Therapy Residency Program at the LSU Health Shreveport Rehabilitation Faculty Clinic. She's also the Associate Director of the Neurologic Rehabilitation in the new LSUH Health Science Center, Shreveport Center for Brain Health. In addition, she serves on the ABPTS Academy of Content Experts. She's published in the area of pharmacology and rehabilitation. She has an active clinical practice in the area of neurological rehabilitation, as well as an active clinical research agenda. She's also been honored as a visiting professor at the renowned Valens Rehabilitation Clinic in Valens, Switzerland. As you can tell, Suzanne wears many, many hats and is incredibly busy. And so today her talk is on post-COVID related rehabilitation, the LSU Health Shreveport experience. Suzanne, I'm going to give it to you to take away.
Thank you, Dr. Arnold. I appreciate the opportunity to visit with you today related to our experience here at LSU with COVID recovery and COVID rehabilitation. So really today I'm going to talk to you more about, or coming from my hat as a clinician, as a physical therapist. And so I'm going to kind of walk you through a little bit of how we came up with our program, and then really try to share a couple of very unique case studies about some individuals that we have worked with post-COVID and kind of their history, their story, just so you can kind of get an idea of when we really talk about this post-COVID recovery, this rehabilitation after you have been, after you've had the COVID virus and are on the other side of it, how it is so unpredictable of how people will respond and the problems they will have after they've recovered. And so I'd like to give a shout to my colleague, Dr. Marie Vasquez Morgan, who has worked with me as we begin to develop this program. So for those of you that don't know, this is our Health Sciences Center here on the Shreveport campus. Our faculty practice clinic is over here in the School of Allied Health Professions. I would be remiss if I didn't show the new medical education building that we are about to break ground on. So I think that eventually a lot of our stuff will move into the new wellness area in this building. And then also to give you a kind of a view of our faculty practice clinic, what's very unique about our program here is that every faculty member has the opportunity to maintain a clinical practice. And so that's what gives me the opportunity, not only as an academician, to then also be involved in clinical work. And so this is where all the things I'm going to talk to you about today have occurred, is in this faculty clinic area. So if we think about these survivors, these people that really have survived this illness, and we look at those individuals that required hospitalization. This was some work from Wilcox that was published back in 2013 that kind of showed the burden of what happens to individuals that are critically ill. That the idea of, we start with this baseline pre-illness, and then we look at the burden on our physical being, muscle, nerve, brain function, and that begins, those things decline, and then we peak at a certain level of burden in those systems. And then after whatever reason we are in this critical illness phase, then we begin to gain or restore some of that function. Right, our muscle function begins to get better, our nerve function, our brain function, and it continues to try to cycle back down toward our baseline level when we're now in the hospital. And then once we're discharged, this is that window of opportunity that we have to think about. What are we doing with these individuals? They now, particularly in the COVID individual, the patient that suffered from COVID-19, is they're alive, okay? They survived. Now what do we do? Is it just enough that they survived this illness, but how do we intervene, and what are those things that we need to do to where we can make sure that they return to their previous baseline, and not that they function at a new baseline of chronic problems. And so this is where we began to look at, what can we do in this phase forward, once we've now recovered. If we were in the hospital, we're out, we're now home, so that we can work to getting back to what our previous level of function was, that quality of life that we had prior to our COVID illness. And so this is kind of where where I'm going to work, or I'll talk to you about, is in this post-hospital area, in that recovery period. So when we started our program, it was back in June of 2020. And how it actually occurred is, a family member of a former patient who had had a neurological insult and had received care in our clinic, now had a spouse that had been in the hospital, been ventilated for many days, weaned off the ventilator, now discharged home, and had some significant problems, and reached out to us to say, you know, Suzanne, will y'all work with him? What can be done to help us try to get him back to his previous level of function? So Dr. Morgan and I began to look at some of the literature, and we did find this article that was published in April of 2020, where Steer and Polick basically looked at some of the old SARS information, and because these viruses were somewhat similar, began to look at what were the problems that we saw in those individuals that survived the SARS infection, and then to make us begin to think, maybe these are some of the things that we're going to see now post-COVID that we need to be able to screen and watch for. And so this is then the list that we use to think about, okay, what are those areas, if we're going to start seeing patients with post-COVID syndrome, what do we need to make sure that we assess and look out for? So certainly functional disability, just from being bedridden, right? The idea of weakness and functional limitations, you know, not being able to climb stairs, not being able to get in and out of the car, not being able to get off the floor, in and out of the bathtub, just those functional components. Also looking at the old SARS literature, we realized that many of these patients post-infection we're going to have a significant amount of pulmonary decline. And we see from the SARS literature that a great number of them really had reduced pulmonary function, and that many of them had some moderately impaired pulmonary function. And so maybe that was where we needed to make sure that we concentrated our intervention. Also excessive fatigue, and I'll tell you, that's one of the things that we see quite a bit of, and you'll see that when I show you some of our case studies. Certainly, we see the idea of maybe some cardiac complications. Now, in our clinic, we're not able to do EKGs to recognize those things, but certainly knowing that from a medical component, those things have to be monitored and watched for. Swallowing complications if they were intubated, okay, if they did have to be put on a ventilator, then making sure that we follow up once they've now been off the ventilator, that they now can swallow, dysphagia, those types of things. Also looking at what we call this ICU acquired weakness, and particularly this neuropathy. All right, we see a lot of that. And it's, for me as a clinician, I'm trying to determine, am I seeing the neuropathy as this ICU acquired component, or is it more related to the COVID virus? And I'll tell you what I think we're seeing, it's more related to the COVID virus. And then again, that muscle atrophy just because of disuse. So here we come into that neurological sequelae and this idea of this polyneuropathy, this Guillain-Barré-like. So when we think about Guillain-Barré, it's a demyelinating of the peripheral nerve, okay? And according to the severity, we lose either sensory or motor function, sensory and or motor function. And normally that is detected by looking at nerve conduction tests. But what I want to kind of reiterate with this talk is the Guillain-Barré like syndrome that we see isn't Guillain-Barré. I think, and after talking with some of our basic scientists over in the graduate program, we think it's probably more a severe inflammation. Because what I'll show you in some case studies, people that had no movement in their foot, their axillary nerve, their common peroneal nerve, that on nerve conduction test looked like demyelination, recovered in about 4 to 6 weeks. So it can't be demyelinated because that recovery of function isn't going to occur that fast. So what we really think, again, after talking to some of our basic scientists, is it's probably a severe form of that inflammatory process that makes the nerve appear demyelinated, but it recovers very quickly. Also thinking of ataxia, there is evidence in the literature that some individuals will suffer a stroke due to that clotting abnormality that we see. I have not personally worked with any patients that have had a stroke that has been related to their COVID infection. Cognitive symptoms, we certainly look at that and screen for those things. Just that idea of that fog that patients think or describe that they're in. We see a lot of sleep disturbances. This was seen in the SARS patients post-SARS, and we're seeing that in all of our patients post-COVID. Many of them have a hard time sleeping, this insomnia, getting back into their normal circadian rhythm. Certainly, mental health and depression. We do a depression screen. We don't call it a depression screen. We call it a quality of life, so that we try to make it somewhat anonymous, so that, you know, people aren't thinking, oh, they're asking me, am I depressed? How do I answer it appropriately? So we're using the geriatric depression scale, but on the sheet that we give the patient or the client, it just says quality of life scale. And then thinking about pain. We've had many that have been hospitalized having these joint contractures due to their positioning on the hospital bed, particularly if they were having to be prone. We're seeing certainly some musculoskeletal components. So these were what we thought when we started in June, thinking, okay, we need to make sure that we assess for all these things. So this is kind of what we came up with our COVID rehab protocol. Certainly, We want that each patient that we see has had a medical checkup, and usually if we've not received the referral from a primary care physician, then we want patients to go participate in our medical COVID clinic to make sure that those cardiac issues, particularly the arrhythmias, are addressed, and also what is the severity of their pulmonary function. So some type of pulmonary function test so that we can see what their tidal volume is, what their residual volume is, etc. And then just to make sure that we have the appropriate general medical workup, particularly with blood work. And then these are what we decided that we wanted to look at based on the literature in terms of some assessments to do across patients so that we can begin to look at clumping some of these individuals together and look at some of our outcomes. So certainly we decided that we would look at endurance as an issue, and we see that with all of the patients. So you do a 2 or a 6 minute walk test. Certainly functional strength. Not really manual muscle testing, because there are many patients that can have a 5 out of 5 if we test each individual muscle, but they still can't stand up. And so we're utilizing the 5-time sit to stand test to look at functional strength of the lower extremity, which we find is probably the most problematic with these individuals, these patients, particularly if they've been hospitalized and bedridden for a number of days. Certainly functional gait. Looking at gait speed using a 10-meter walk test. And we know what is normal gait speed. You and I walk at about 1.8 to 2.0 meters per second as our preferred gait speed. And so as you'll see, many of these individuals are much, much slower in their walking. And some is due to weakness, some is due to neuropathy, but in many individuals, it's due to their pulmonary issues. Berg balance is a balance test. Timed up a go as looking at their fall risk. And then these things that we don't normally, up until I started working with patients that have recovered from COVID, I can tell you as a practicing clinician for 30-something years, I hardly ever used the fatigue severity scale unless I was working with a patient who had multiple sclerosis. So we pulled out some of these assessments that are validated and reliable in the literature that will give us some information about fatigue. And so we picked out the fatigue severity scale that gives us a level of fatigue doing your daily activities of living. The insomnia severity scale, again, we saw in the SARS population that many of these patients suffered from the inability to sleep appropriately. And as we know, with a lot of the literature that's coming out now about the importance of sleep, not only on your physical health, but also your mental health, we wanted to make sure that we assess those things. And then very unique to our practice clinic, we utilize something called the patient-specific functional scale. This is a participation or a quality of life scale where we ask the individual, can you name for me 3 to 5 things that are important to you to get back to? So it goes back to that original slide about our normal baseline activity. Our faculty practice clinic is based on what we call patient-centered rehabilitation. The idea is that we want to provide what is needed for those individuals, for them to get back to the quality of life that is important to them. And the reason we call it patient-centered is that we're going to provide the evidence-based intervention that is needed to get that patient back to what they perceive as their quality of life without thinking about whether insurance is going to pay for it, is it covered? So we don't practice what is reimbursement-based rehabilitation. We only do what we're going to be reimbursed for. We practice what we call patient-centered rehabilitation. And we do that across all 3 of our professional areas in our faculty practice clinic, both physical therapy, occupational therapy, and speech therapy. And so it was important for us to make sure that we ask those patients, what is it that is important to you as an individual to get back to? And then also this neuropathy. Again, we saw a lot of people that have these peripheral neuropathies that have both decreased in conductance and amplitude in nerve conduction tests. And any literature will tell you if you want that nerve to recover, then you need to provide functional electrical stimulation, send a current down that nerve to help it recover in a more appropriate or in a faster time frame. So again, patient-centered care, trying to identify the impairments that were present with each individual patient. And as you'll see with the 3 patients I'm going to do case studies for, they were all very different. They all were suffered post-COVID problems, but they were all very different. Then try to figure out what's important to them. What are those task-specific functional things that they wanted to do, and then try to retrain those functional goals. If it's swinging a golf club, if it's climbing stairs, whatever it is that was really important for them to get back to, that they felt like they couldn't do at this moment in time. So this idea of patient-centered care. And so when we think about neurological rehabilitation, we're very fortunate in that we have a lot of those technologies that will help us do that. Certainly with functional training, as you'll see in some of the video I have for you, many of these people couldn't walk by themselves. And so the ability to get them up and to practice walking, you know, what we know from our motor learning and motor control literature is that if you want to practice or you want to regain a task, then you need to practice that task. So the vector system for functional strength training and functional activities, again, trying to look at improving their pulmonary function, as many of them had issues with that. Functional electrical stimulation for those neuropathies and atrophy of the muscle, again, trying to recruit as much of that muscle return as we could. Trying to work pretty consistently with the critical care physician, and I shout out to Dr. Keith Scott, who worked with us tremendously in trying to, from a medical standpoint, manage some of these things, and then referral to other services. Certainly our occupational therapists participating with hand function and those activities of daily living, speech therapy, and then if we did see anyone that had some depression issues, then referring them on over to our clinical psychologists in our psychiatry department. So, any questions so far about anything we've done, kind of where we're coming from? I think it's pretty self-explanatory in how we came about with our program, looked back in the literature to see what we make sure that we identify related to the SARS pandemic or epidemic, and then being able to move forward with some of our patients. And so what I thought I would share with you so you could kind of see the variety and the asymmetry that all of these individuals have, I've got 3 case studies that I'll show you.
Suzanne?
Yes.
I got a question. John Kerwin here.
Yes, sir.
I missed the very first part of this, and I was wondering if these patients are considered long haulers, or are these just patients who had COVID and didn't really have any diagnosis of whatever the diagnosis is for long haul?
The first 2 patients I would consider long haulers. They were both hospitalized many days on ventilators. The last patient I will show you, I wouldn't really call her a long hauler, but I would call her a chronic COVID, because you'll see that she had COVID almost 9 months ago and we're still having issues that went unresolved.
Mm-hmm.
The first 2 I would consider in what I think we think of as long haulers, and then the last patient would be more of a chronic patient. Okay.
And one last quick question: how many patients are you following in your program?
Right now, I currently have 2 in our program total. We've had about I think 17 that we've been able to work with.
Excellent.
And I think the issue is, and one of my ideas of liking to do this kind of stuff is to try to make people aware that it is okay to let somebody know that you're having an issue. You know, the last patient we had didn't think there was anything that she could do, and it's been 7 months. And so I'm hoping that doing things like this will let people know, even if you weren't in the hospital and you don't have the severity that these first 2 individuals had, if you have an issue, there are some things that can be done. Please reach out to somebody. Okay.
Excellent. Thank you.
Great. All right. So our first patient was hospitalized in March. All right. Required ventilation and ECMO support. Was on the ventilator 47 days. Okay. Discharged home now in May. His main of mobility was a wheelchair. He could ambulate with a rolling walker, but needed assist at least ×1. His resting heart rate was 115, and his oxygen sat was 95. And what was unique about this guy is that he could tell you when his oxygen sat got down, but he didn't perceive that he was short of breath until his oxygen sat got into the low 80s, high 70s, which was very problematic for us. So we were monitoring the entire time because we didn't want him getting that low. So if we look at some of our standardized assessments, again, not being able to walk too much at the 2-minute walk test and that really exerting him, and his oxygen sat dropped. His normal 5-time sit to stand, which is functional strength, was 27 seconds. Normal is 10. Gait speed was about 0.5 meters per second. You and I walk at about 1.9, 2.0 meters per second. His Berg balance, he was at a fall risk. Same with his timed up and go. Normal timed up his go is 10 seconds. It took him 20 with his rolling walker at a fall risk. His fatigue severity scale was at 44%, which tells us 44% of the time he felt like fatigue interfered with his activities. He had a 16 on the insomnia scale, so that tells us he's at kind of that sub-threshold for insomnia, and so certainly wanted to think about that. Quality of life, how this is done is you ask them what their goals are, and then at this moment in time, where are you on a scale from 0 to 10 to do that activity that's important to you? 0, you can't do it at all. 10 is you do it like you wanted to. And so for him, his average was 2.6. So that was saying based on the activities that were important to him, he perceived himself at about 73% disabled. He had drop foot on the right, which is then that polyneuropathy of the common peroneal nerve. And then he had some really, really tight gastroc soleus, about -4 degrees. And I think that's from being prone. When you lay prone, your feet are in plantar flexion. And so therefore his feet were down instead of up. And I think that's merely from just the way he was positioned in the hospital. And so what we tried to do, if you want to learn to walk, get better, get off the walker, we had to get him in the vector system to let him practice that. Certainly worked on his pulmonary function, and again, would not let his oxygen saturation get too low, because then that's hard to rebound from. Did quite a bit of FES, functional electrical stimulation, particularly to that right ankle where he had drop foot. We put him in a brace for a short period of time, and then we did some rigid taping for his upper extremity. All right, so here is this individual. All right, just so showing us that how we were trying to get him. This is our vector system that allows us to de-weight him, take some weight off of his body for to allow him to walk. So this was at a point when if he wasn't, he was de-weighted about 50 pounds. And so just having him walk and practice that normal gait cycle. We started out with the walker, and then he got him off the walker. So here's some things, again, trying to work on his balance. Again, he had a lot of lower extremity weakness, so just doing some lunging, again, in the vector system, so he's not going to fall. Okay, and having him see how low he could get. If you remember, his 5-time sit to stand was 23 seconds, so that's working on lower extremity strength. And then this is him as we're beginning to progress him with his gait cycle, and then beginning to load him back up, all right? But again, the idea that we're not touching him, so he's really working on his gait cycle, what it feels like to walk, and relearn those activities. All right. And then again, trying to really challenge him and doing some lunging. We're probably helping him, got about 20 pounds, helping him do that so he could come up. He could go down, okay, but he couldn't necessarily get up. So you can see all this accessory breathing we have going on here. Then trying to get him to breathe deep, get air down into those lower lobes. And then trying to challenge him a little more from a balance standpoint. If you remember, he was at risk for falls, his balance. So just trying to challenge and working on those balance issues in an upright posture. So working on softer activity, having to step up, step down, walk in a tandem gait, trying to challenge. And here he's got his full body weight on him. We just got him in the vector so he doesn't fall. And then one of his goals is that he wanted to run. And so we let him begin to practice. I mean, that was one of his goals, to be able to run back on his treadmill. And so letting him practice that component. All right, so here were some of his outcomes. He did quite well. We got him up to doing about, instead of the 2-minute walk test, we had him now in the 6-minute walk test, walking about 1,500 feet. We got his 5 times sit to stand back down to normal. 10 or less is normal. His gait speed improved almost 3-fold. Didn't quite get him back to what you and I would be, but working on it. His Berg balance, no risk of falls, timed up and go, 10 seconds is normal, no risk of falls. From his fatigue, we reduced him from 44% to 11%. His insomnia scale, now we're back. I think having all that activity and really having him work then helped him get back into his normal circadian rhythm. For his patient-specific goals, he was at a 73% disabled. By the time we discharged him in about 2 months, 8 weeks, he perceived that all the 5 things that were important to him, he could do 10 out of 10, no disability. We provide E-stim FES to that foot drop on the right. And by the time he was discharged, he had full function of his anterior tib, common peroneal nerve. So that tells us it wasn't demyelinated. I think it was in severe inflammation. And then where he could not get his feet back to normal range, we got him 12 degrees of dorsiflexion on the right, 15 on the left. You need 12 degrees to have a normal gait cycle. So I think, again, all that activity of him walking helped, because he would tell you when he walked, as he stepped through, oh, that makes my ankle stretch. All right, the second case is a 43-year-old male, big weightlifter. He probably lost over 100 pounds of muscle mass. He was hospitalized in June of 2020. He was on the ventilator 42 days, discharged home. He did ambulate when he left, but he had, again, drop foot of his left ankle, and he had a subluxation of his left shoulder that I think was axillary nerve palsy because of how they had him positioned. He was 6'5". So I'm thinking that they had him, the way they had him positioned for proning probably stretched his axillary nerve a little bit. Again, his resting heart rate was quite high, but his oxygen sat was okay. So looking at some of those same things, though, not really able to walk very far, certainly weak in his lower extremities. Remember, 10 is normal. Slow, you and I walk at 1.7. Much less of a fall risk than the first patient, but still perceived that fatigue interfered with his activities, about 63%. He did not have insomnia. 1 means normal, no insomnia. If we looked at what were important to him, those were getting back to work, working out in the yard, and being able to function around his home. He perceived that he was able to do those activities at this time at a 4 out of 10 level, so that which made him 54% disabled. He had a severe foot drop. Manual muscle test of dorsiflexion, pulling his foot up, is 1 out of 5. And his right upper extremity, he had no deltoid activity at all, okay? 1 out of 5, no grip strength. He had a 3-inch shoulder subluxation. And so here's an x-ray. He thought he had dislocated his shoulder, but really it was because he had no deltoid musculature holding the head of the humerus in the glenoid fossa. He was having to rely on his supraspinatus, and it just couldn't overcome. And so that's a pretty significant, what we call, it looks like hemiplegic shoulder, but shoulder inferior subluxation due to a lack of deltoid musculature. So again, that patient-centered care, what was important to him, what were his impairments, we tried to fix. And so here he's got an AFO. He certainly had drop foot. So we provided a functional electrical stimulation to that common peroneal to try to get that movement back in his foot. E-stim, you can look at the sulking of his infraspinatus and supraspinatus, and then you can see how flat his arm is right there. He was total atrophied in that upper extremity due to the axillary nerve palsy or polyneuropathy. Also, he had no grip strength whatsoever. He couldn't make a grip with his left hand. So again, trying to activate that ulnar and median nerve to get grip strength back. This is what we did initially. I didn't have a picture of him. So this is a picture I took out of one of my lectures, that we used rigid tape to tape his shoulder back into socket until we were able to get him some kind of brace, because we didn't want to get that stretch weakness and then to have that glenoid, that the head of the humerus press on all of those nerves and arteries that follow in the axillary space. So we did this rigid taping with him. And also just in strength training, lots and lots of strength training with that individual. This is the AFO we put him in initially to prepare to fix the drop foot. And then once we were able to get him a sling to keep his head of his humerus in his glenoid fossa, again, not to try to eliminate some of that stretch weakness and other problems until we got the deltoid to come back. So here are his outcomes. He was able to almost double his speed or his distance. And then by the time we discharged him, started in August, by the time we discharged him in November, he did not need that AFO. He had dorsiflexion. His functional strength back to normal, 10 is normal. Gait speed increased to 1.6. Here he needed an AFO, here he did not. Berg balance back to normal. Reduced his fatigue about 44%. Still his insomnia scale, no insomnia. And then what's important to me as a clinician is his patient specific, those things that were important to him that he identified. By the time we discharged, he was back to 10 out of 10 out of those activities. So no disability. And this is where I'm telling you that polyneuropathy isn't demyelination. We got his ankle strength back to 3 out of 5, and his deltoid went from a 1- to 4+ in 4 months. And if that axillary nerve had been truly demyelinated, you wouldn't have gotten that back that fast. He went from 0 foot-pounds on his grip strength in his left hand to 32, and then no shoulder subluxation, and very much reduced his resting heart rate and improved his saturation. All right, in the few minutes that we have left, I'll go ahead and do the third case. I added this lady just this week when I found out I was going to have more time, because I think this shows you the two extremes of what we're seeing. The first two individuals, many days in the hospital, on a ventilator, very typical of what you would see with that chronic illness, ICU illness, with all the atrophy and the problems that they had. But this was an individual, a lady, who was 41, and her history goes that back in February of 2020, she had pneumonia, of which she thought she recovered from, but then in July of 2020, she contracted COVID and then had a recurrence of her pneumonia, in which her physician told her that he thought that maybe she probably never really got over the February pneumonia appropriately, and then it set her up for now this COVID pneumonia induced. So she was first, when she contracted COVID and was diagnosed, she stayed at home 9 days. But then she got to where she had such a hard time breathing and her activities that they decided to take her. And so she was hospitalized again for 8 days and then discharged back home. And when she was discharged home, she was discharged home on 5 liters of oxygen and told to try to wean off. And that was it. And so she then, for now 7 months, had been on and off steroids because of pulmonary infiltrates, would try to get off, lower her oxygen, couldn't, would get on steroids. So we did this for about 5 months until she finally decided, I need to try to figure out what I can do to make myself better. So she came to see us. So on the day that we evaluated her, she had been off her steroids for 20 days. And her complaint was some pain in her joints, hips and knees, and had some specific numbness in her right scapula and her right arm that we were trying to determine, was it more the C6, C7 nerve root distribution, or was it more the median nerve? Okay, so were we seeing nerve root activity, of which we've seen quite a bit? Now, not in any of these patients that I've shown you, but I've got 2 patients that were seeing nerve root inflammation. And with her, trying to denote, was it nerve root or was it the median ulnar nerve distribution? And these were her goals. She wanted to sing in church. That was her. She was part of a singing group in her church, and she wanted to sing. She wanted to go back to work. She had tried to go back to work, couldn't, been home, had tried twice to go back to work, and the fatigue and the shortness of breath was just too much. And then walking without fatigue, so that she had gained some weight, and she's like, I know I need to walk to lose weight, but I get so short of breath. And she described that she's noticed that she's been increasingly having a greater difficulty taking a deep breath. So it makes me think of kind of that fibrosing stiffness occurring in her lungs. Her resting heart rate was not outrageous, and her oxygen sat was at 98. All right, so here were her, where she started in terms of her, the initial things that we looked at. Endurance, about 450 feet. Her 5 times sit to stand test, 18, had some strength issues. Certainly walked pretty slow, 1.9 to 2.0 is normal. Was not really at a fall risk in terms of her Berg balance. She described that she felt fatigue interfered with her activity, her daily activity, about 63%. Had an insomnia scale of 12, so insomnia was an issue with her. On her patient-specific goals, sing in church, go back to work, and walk without fatigue, she felt like she was about a 5 average, so 50% disabled. Her shortness of breath, okay, her score was a 43, that she felt like her shortness of breath interfered with her activity about 36% of her day, which is pretty significant. Yet her resting heart rate, 77, oxygen sat 95. And again, we were kind of concerned about this numbness in her C5, C6 nerve root, which is what we see with that peripheral neuropathy. It hadn't progressed to her to be motor involved. Hers was just sensory involved, where our other 2 cases actually had motor involvement. So the reason we thought it was probably C6 is she had quite a bit of numbness in her posterior scapula. And then this is where the numbness and tingling was in her hand. So we were thinking C6, C7 nerve root. So when we did functional electrical stimulation for her, we tried to really get the E-stim up more proximal, because she was suffering from, I think, nerve root inflammation and not peripheral nerve inflammation. So as you see, she didn't have all of that muscle weakness and those things that the first 2 individuals had that I think could be related to their bedridden. Hers was mostly related to her pulmonary function. And Dr. Scott describes those lungs after inflammation due to COVID, that they become very sticky. And so they have to be kind of, those alveoli have to be kind of forced open. So we did a lot of things to try to improve her pulmonary function and make her really work on her proper breathing techniques, what we call pursed lip breathing to really try to get air down into those lower areas of the lungs to pop those alveoli open so she could feel like she could take a deeper breath. And we did that with activity. So we did a lot of aerobic activity with her, just monitoring her respiration and how she breathes. Certainly did some E-stim to the C6 nerve root, and that resolved. And then we gave her a lot of things to do at home. So we saw her for about 5 weeks. So her 2-minute walk test more than tripled. Her strength got better. Her gait speed got back up to what we would consider normal. We reduced her fatigue about 20%. Her insomnia, 1 to 7 is normal, no insomnia. So we got her back to where she was sleeping pretty good. Where she started out with her things that she wanted to do, sing in church, go back to work, be able to walk without being short of breath. She went from being 50% disabled to about 17%. She reduced when she felt shortness of breath, interfered with her activities about 10%. And what I thought was really unique in that short a period of time, by providing FES to that nerve root, we returned her sensation in that right arm back to normal. And so what I want to play for you now, we'll finish with this, but this, I can tell you all these things about objectively what we made better, how her strength got better, her sensation got better. But one of her patient-specific goals is that she wanted to sing in church. And so I'm about to show you a clip. Give me a minute to get it up. And this is her singing in church for the first time since she contracted COVID. And so she brought us this video for us to see.
It's only because he lives I can face tomorrow. Oh, because he lives, I'm telling you, all my fear is gone. Oh, yeah. Because I know, yes, I know he holds the future in his hands. And this life is worth living just because he lives.
So I'll end with that. That's what's important. She has not sung in church since she contracted COVID because of her issues. So a shout out to my colleague, Dr. Morgan, Dr. Keith Scott, who works with us in trying to help manage many of these patients. And then also the patients themselves and their families that sought out to have some interventions. So that's all I have. Is there any questions?
That was just a great presentation, Suzanne. Do you notice an age difference, Suzanne? I mean, are you seeing more? Those look like middle-aged, what I would call middle-aged patients.
They are, and that's primarily the group I'm seeing. And primarily, the majority of them are middle-aged males. And it's making me think, as I ponder that, I'm wondering if then the older population is just not seeking out that intervention because they're not having to go back to work and those things that are important for their support of their family. And
right.
I'm wondering if there are those that are a little bit older that are having issues, but they're thinking, well, maybe I'll not say anything, or, it'll get better over time. I'm primarily seeing the middle-aged group. And I think it's because they're recognizing that they're not being able to go back to work, not being able to care for their family, not being able to do the things that they want to do. And it seems more problematic to them.
Gotcha. Have y'all had any 20 to 30-year-olds?
I've had one who was a 21-year-old that was an Ole Miss student that had some major issues with heart arrhythmias and then being short of breath. And so we were trying to work with her cardiologist in monitoring her with her heart arrhythmia, but also trying to get her back to where she could go back to college. So I've had one that's been under the age of 25.
Okay, you did have a question, Suzanne, from Paul Fidel, and he says, are you currently working with any of the long haulers, which you said originally the first two are what you would consider long haulers, and the third patient you would consider chronic COVID. But how different is the approach is what he would like to know. What are the differences you're seeing?
Well, again, the approach is different based on how they present. So the two long haulers had those things that we think were very typical of people that stay in bed for 42 days with just wasting away, muscle atrophy, generalized weakness. And so those were pretty much treated the same way in trying to restore muscle function back, just everything's getting them to be able to walk without the use of an assistive device. So again, very typical of people that we see in bed for a period of time. But how the chronic people are different is that there's not a multitude of issues. The third patient that I showed you, her two issues were two things: shortness of breath, and then that numbness in that one particular C6 nerve root. So I find that the chronic component, they don't have the whole gamut of problems. We're seeing one or two, but they're not always the same, if that makes sense.
Yeah, thanks, Suzanne. I was actually thinking more about on the amount of time that they were sort of bedridden and sort of what they were dealing with after it was all over. But you had a pretty good response with those during the rehabilitation. I guess I'm asking whether or not you've been working with any people, have gone 6, 7, 8 months with all this fatigue and all these added problems from what we'll call the long hauler syndrome, I guess, if you want to call it that. And is it possible that through these rehabilitation processes that they can be brought back as well as the ones you've worked with?
I have not, but I would certainly like the opportunity to try, because I think they can be. I would think that somebody that was a long hauler back a year ago that is still having some significant issues with muscle function, numbness, shortness of breath, the whole gamut, I would like the opportunity to try, because I think it can be reversed. It's providing the appropriate intervention, and sitting at home and letting nature and time take its place isn't what's going to make it better. I feel for the last patient that I showed you, she honestly was at the point that she wondered, was she ever going to be able to get back to her normal life? Because she had now gone 6 months, 6 to 7 months with, she wasn't really that sick, but we were still, and people just kept saying, give it time, give it time. Well, she didn't have time, in her mind, I want to get back. And so to answer your question, I think those that were like the first two that maybe didn't get intervention immediately and now have been at home with the buildup or just a continuation of all of those problems, I think they can get better. It might take a little bit longer than the 4 to 6 weeks that we were able to do when we hit them right away, but I would certainly like the opportunity to try.
Yeah, I would say hopefully we're going to get the chance, if we get these networks going with part of LSUHS and the funding that we're trying to deal with relative to this long hauler syndrome. I hope we do get the chance. That's great work.
And I would be happy to participate in any way possible. And we don't turn anybody away.
This is Frank Greenway. I was interested in your neuropathy, and you mentioned the lack of sensation and the lack of motor strength. do you have any of the other symptoms of neuropathy that's typical of diabetes or post herpes type of thing, that where you might think of a viral type of injury and inflammation?
No, sir, and that's what is unique about this, is that really they present like it is a true demyelinization, where they lose sensation first, and then they lose and/or motor function, but we don't get any of those other things like pain and burning and needles, none of that. And the ones that I've seen, the peripheral neuropathies are numbness and weakness. None of the others.
Thank you.
But it's not demyelination because it recovers too fast. Any others? Well, again, I appreciate the opportunity to share what we're doing here at LSUH-Shreveport. If I can assist anybody, or if anybody has any questions, you can certainly find me on the website. And I'm sure that Megan would, I don't mind if Megan shares my email or office numbers, put it up somewhere where you can contact me. I would be happy to help. If you are in an area where you have that patients can't get to Shreveport, and I could help some other therapists in other areas learn from what we've done here, I'd be more than happy to do that, because it is my goal for the citizens of Louisiana that have suffered from COVID-19 and have issues, that we get them back to the best quality of life we can, and hopefully the quality of life they had before they were contracted the virus. So, Dr. Arnold, thank you so much.
Great. That was a great presentation, Suzanne.
Awesome.